We do use computational techniques, but I think they're at the very low end of computational techniques. So, of course, we've got computational software. For example, we measure bone mineral density regularly in our patients, and there's computational software to interpret the measurement of bone density in the scanners that we use. We also use some computation in risk algorithms. So in Sheffield, we developed a risk algorithm called the FRAX tool. And again, that's a very sort of low-end, very simple mathematical calculation of risk. In terms of high-end computing, to date we use relatively little, but we're increasingly becoming aware of the potential that brings. That particularly in imaging and functional assessments and other approaches like big data, we know that there's all sorts of potential interactions that we could have that hopefully in the future might help to inform us about an individual's trajectory in more detail and allow us to tailor their treatments in a much more specific way. The interactions I've had with the Centre of Excellence have really all been local ones. So in Sheffield we obviously have groups within the university that form part of the Computational Biomedicine Centre of Excellence, and that's largely through the Insignio Institute in the University of Sheffield, and I've been working with them probably for about the last 6 or 7 years now, mainly focusing on image interpretation and improving the analysis of 2D and 3D imaging to give us a better readout on bone strength from those images, rather than perhaps just focusing in on the traditional 2D measurement of bone density, which works quite well at a clinical level, but we all think that we can probably do slightly better if we can take the three-dimensionality into account. And not only that, but marry that then with the other soft tissues around the bone, the propensity to fall, the dissipation of the energies and so on, that can actually give us a better idea about the potential of fracture in that individual's bone. What I think the potential for something like CT2S is that it's not just looking at bone, it's taking the fall characteristics into account, and not just a sideways fall. It's taking different loading conditions and different angles of falls and things. So it's really giving you a really good exploration of how the bone's going to perform under a variety of conditions, many of which might occur by chance at some point. And I think that's going to be the most useful thing. And I can see the potential added value of it. What we would like to do is really take that out into prospective cohorts and say, this is what you're doing today, and that's got a discriminatory ability of that. But by adding in CT2S, then we can improve that discrimination.
I have some projects with Sheffield since now more than 5 years, and everything was based on flow dynamics, and one of this project that was used for a PhD thesis was 1D model, to develop a 1D model for one subject in my specialty, that is vasospasm. It means that when you have an intracranial hemorrhage, vessels start to shrink a little bit, and you don't understand exactly what happens in terms of hemodynamics. So it's so complex and it's so unpredictable that we decided to start the research with 1D model before trying to create, simulations, etc. So to try to understand a little bit more with 1D model. At this time, CompBioMed was also developing 1D model for another kind of research. So it was natural that maybe both projects come together because we were a little bit more advanced, if you can say that, in some part of this project than the CompBioMed group. So they invited us to be part of the group. So that was the first approach. Another point was that one big subject to be discussed, I think, for CompBioMed too, is stroke. And I have some expertise there. So the second part, and I was invited personally to be part of the group, is about stroke. So it means occlusion of intracranial arteries, treatment of intracranial arteries. There is a big clinical interest, is a big commercial interest. I mean, it's like, how can I say, it's like cancer, like big pathologies that heart attack, I mean, stroke in terms of healthcare system, it means a lot. So with my expertise and also with the project that you are developing in this field, we are very glad to be part now of the CompBioMed.
Yes, we use computational techniques at the moment. We use them both in our PCI environment, but also in our structural heart environment. Within the PCI environment, we use computational fluid analysis, particularly on CT scans. So we apply computation on the CT scan to test whether or not certain coronary stenosis is flow limiting or not. But we also use computation in preparation of transcatheter heart valve intervention. Let's say before a transcatheter aortic valve implantation. And this is also mainly based on CT scan, which we performed prior to intervention. And we then use computation to plan our procedure. My primary interaction has been with LifeTech Group, which is also based here in Eindhoven, not far from the Technical University and not far from our hospital. And we had a very fruitful cooperation so far. So this does not only narrow down to what we should do based on a certain project, but we also create spin-offs of these projects. One nice example is, for instance, that recently two PhD students performed or designed actually some sort of an app which we as physicians can use in order to plan our coronary intervention strategy in patients with coronary artery stenosis. And this is simply an app which can be installed on your phone, which you can use during a heart team meeting together with the cardiothoracic surgeon. And based on this app, you can then decide whether a certain patient should be treated with a stent or with a bypass. And this app uses computational fluid dynamics, computational calculation, well, this is, I think, a potential step forward in order to optimize treatment strategy in patients together with computation.